Yes, first I'd like to thank to be invited here today to bring a perspective from the OECD, Organization for Economic Cooperation and Development. And as Sheila said, that is mainly focusing on developed countries. But I think it's very relevant to see how the approaches on how to link improvement projects with health system performance are taken up in OECD countries, how that could be applied or could be seen as a model also to be used in the lower income countries. So now I have my slides. OECD perspective. Basically, I want to make 4 points. If you want to improve the link between the programs that USAI aid is funding with health system strengthening, then the 4 routes to do that are to see how it links to the health system performance. Secondly, you will find that in many countries that implies strengthening the information infrastructure. So how does your project contribute to that? Thirdly, how is it aligned with and can be structurally embedded in national quality strategies and the quality improvement architecture in the country? And fourthly, how can the process of the execution of your project help to make the shift from innovation to implementation? The OECD has been producing statistics on the performance of healthcare systems since a long time, and since 2005, this is the framework we are using. It's based on the IOM work. It recognizes 4 functions in a health system, but we have a more restricted focus on quality. We report on effectiveness, safety, and patient-centeredness. And alongside, we report on the access, mainly financial access in the healthcare systems, the actual expenditure, and you see 2 kind of cross-cutting themes. We try to report on the efficiency and the equity. This means that when we report on performance, and I'm now really cutting it down from hundreds of indicators to the ones that are mostly used when we talk about quality. Yes, we still report in all the countries the vaccination rates for infectious diseases and flu vaccination rates. We report infant mortality and maternal death. But we also report already for 10 years the 30-day case fatality rates for AMI and stroke and the trends therein. We report the data on cancer, mortality data, screening data, but especially 5-year survival rates. We report the potential avoidable hospital admissions as a proxy over the functioning of the primary care system for chronic diseases. We have some parameters for mental health care, amongst them excess mortality in persons with severe mental health problems. And there's a lot of work going on reporting already for 8 years on patient safety indicators and patient experiences, notably international standardizations of core questions that have to do with respect, autonomy, and communications. That means that there are this kind of tables that show you the progress and the outcome on cancer. Here you see the results in 2 different time periods. Last year, the OECD produced a report where we did analytical work on these trends, basically showing that improvement is not just linked by the amount of money you put into it. That was the strongest association. But you also see a strong association with the maturity of the governance model. Are the debates going on centralizing cancer services? What is the speed with uptaking of new cancer drugs? What kind of decision making and compliance with evidence-based medicine approaches? So we try to characterize the systems and do explorative work to see whether that associates with the progress made. Similarly, here you see the trends in improvements in 30-day case fatality for AMI. We have similar ones for stroke. Good news is that it's getting better in all the countries. This year, we will release a report where the analysis has already been done, where again, we try to relate the speed of improvements to the kind of design features that the countries took in designing their care for AMI patients. That means the whole full cycle from signaling, ambulance, emergency, and what kind of therapy are given. Again, bottom line, strong association with the richer countries do the better. But we see that we can also make it plausible that there is an association with how much policy emphasis you give on improving. That's the first. So the point I would like to make, of course, is it would be good to broaden this kind of information also to middle income and low income countries. And actually, we released a study together with WHO. This is released every two years Health at a Glance Asia Pacific. That includes all the countries in the region. And the good news is that you will find now a lot of cancer data. The kind of cancer registries are improving in that region. We still have a lot of problem with getting good data on 30-day case fatality rate, but at least we try to shift from just measuring infant mortality and vaccination rates towards the new morbidity patterns of cancer and cardiovascular diseases. So to strengthen the health information infrastructure, the basic elements are: does the death registry function? What is the level of development of the clinical registries, starting with the cancer ones? And what is the level of detail of the administrative databases? There we now see a big development with the universal health coverage. A lot of countries are setting up new financing mechanisms. We try to bring the message across that when you do that, you should also think about using those databases potentially for assessing the performance of quality in your system. And actually some Asian countries are now consulting countries in Africa to help them do that. Also a lot of work on electronic health records, but more monitoring the progress made in the member states and try to standardize surveys. Here I'd like to refer again to a report in 2013 when we made an inventory in 20 countries of their information infrastructure, and there's now systematic monitoring going on, especially on linkage capability and implementation of electronic medical records in the member states. It's an ongoing debate, but for low and middle income countries, especially these first things on the list, death registries in place, starting with the basic clinical registries and making your administrative databases potential useful for, for measurement is important. The third point, embedding project activities in national quality strategies. In the past 5 years, the OECD has been asked by a long list of countries to do an in-depth analysis of their national quality strategies. You see here the kind of framework we're using to describe what is going on. So we look at the overall governance and framework. Then basically we look at the input. How do you assure the quality of your doctors and nurses? How do you assure the quality of your hospitals? How do you assure the quality of the technology you're using? We look at the standardization processes in the system, guidelines. We look at the patient role, indicators as a way of reporting, safety strategies as a specific element, and quality improvement programs. In-depth reviews are there. Point I want to make here, if you do quality improvement projects, there is a link with these strategies. The 6 methods that we have been discussing here today, one of them is an educational strategy. Is it linked to the national strategy on continuous professional development? There are 3 strategies that have to do with management development, 2 with single loop learning, and I would personally say the collaboratives are double loop learning. There again, does that fit with the overall idea about management development in the country? And especially when you start with the methodology with double loop learning, which assumes a lot of freedom for people to take up responsibilities, is that compliant with the management structure, the top-down control structure that a country has in place? And the other 2 methods that you're addressing, supervision and accreditation, do they fit in the overall governance model? At this moment, in a lot of OECD countries, there is an ongoing debate on how to balance inspection functions with accreditation functions, and there's a plethora of institutionalizations going on how countries try to deal with that. So it would be interesting to see how these developments in low and middle income countries can actually be linked to the further development and strengthening of these policies and create synergy instead of trying to get different ways of moving in the same country. Last but not least, just to say that this is not imaginary. As I said, we did work with WHO in the Asia Pacific region. Actually, we have a network there now for 5 years where we try to assess quality of care, but we also did an extensive survey on the quality strategies there. Methodologically, this is self-reported data, but we have a network where we discuss the results with the countries, just to show you that out of the 26 countries in the Asia Pacific region, and so you have to think about Thailand, Sri Lanka, Fiji Islands, Timor-Leste, Papua New Guinea, 16 of 26 say they have a mandatory system for continuous medical education. 8 report that they have a mandatory accreditation, and 13 have in some way a voluntary accreditation, could be just in one pocket in one region of a big country. 15 out of 26 countries say they have some sort of technology assessment function in place to have a discussion on the drugs they allow to be reimbursed in their country. 23 out of 26 report they have standards on safe blood use and can demonstrate that, and 21 out of 26 say they have a pharmacovigilance system in place. So this is the thing to build on. Fourth point, that's more when executing a project, how to make sure that it can be implemented. And we heard already a lot of ideas, but it probably has to do with the alignment of the R&D and the service and system change. As I said, especially this management development thing, if your project has a lot to do with management development, has a certain philosophy, is it there? Especially if you want a kind of re-engineering of your system, is this not bouncing with the existing interests of professionals, managers, or policymakers? So it should be in that respect aligned, and I hope this meeting also helped to have a clearer understanding how you can make a pre-assessment whether a certain strategy with its implicit notions actually fits the kind of development, and especially when you want to use a strategy to introduce system change, then of course it gets a more political dimension, and roles and responsibilities of professional groups and managers, or strengthening of nurses' roles, all these things become an element of your change process. Secondly, the interaction of the project itself with the system as a whole, and there the point is that should not be just at the beginning, at the end, but there's a lot of literature, and especially on how to make health services research in practice, how in every phase of your study and research there is an interaction, and a meaningful interaction with the policymakers and the system. So these are the 4 points I would bring you as a perspective on how to make the link between the programs and the projects you want to do on quality improvements and the strengthening of health systems. Thank you.